Every drug is a poison. It's only the dose that makes the difference. Paracetamol poisoning. How many of you think you're confident in managing a patient with paracetamol poisoning?
No matter how many we treat, every case is a new one, sir.
Let me tell you a story. Daniel Welch was a 19-year-old girl who had short stature, high BMI, and she had chronic pain syndrome. And she was always taking analgesic medication. One day, her parents took her to a hospital in Scotland in June 2008. She had upper respiratory infection. The doctors diagnosed upper respiratory infection with possible bacterial infection, did some blood tests, discharged her on some painkillers and antibiotics. She was 19 years old and she weighed 35 kgs. She went home, but she was unable to take the painkillers and the antibiotics because she was continuously vomiting. 2 days later, she came back to the same hospital. She was admitted to the hospital, and the doctors who admitted her prescribed her 1 gram IV paracetamol 4 times a day. She was 19 years old. She weighed 35 kgs. She received 1 gram IV paracetamol for the next 48 hours, 4 times a day. 2 days later, she became unwell, had deranged liver functions, developed acute liver failure, and was transferred to the critical care unit in a hospital in Glasgow, in Scotland. She was seen by 11 doctors and 12 nurses over the course of her admission in the hospital. On the evening of transfer to the critical care unit, she had a cardiac arrest and died. She was 19 years old. She weighed 35 kgs. She received 4 grams of IV paracetamol for 48 hours. She was seen by 11 doctors and 12 nurses. None of them calculated the dose which was needed for that girl. And a young life was lost. She was to receive only 35 into 15, 575 milligrams of paracetamol 4 times a day. She received 1 gram 4 times a day. How many of you are confident in treating a patient of paracetamol overdose? Paracetamol overdose is the commonest poison in the United Kingdom. It is the commonest cause for acute liver failure. It's the commonest cause for which reason patients need a liver transplantation. And it's all related to this molecule called as NAPQI. So what are the types of ingestion? what are the common pitfalls? I've already alluded to one pitfall. And how do you manage? Most people think they know how to manage paracetamol poisoning. As a toxicologist, I can tell you that it is the most common poison which is most badly managed by physicians all around the world because they don't understand the types of ingestion. There are 3 types of ingestion with paracetamol poisoning. Firstly, it's acute ingestion. So you could take paracetamol over a period of 1 hour, and that is acute ingestion. Second type of ingestion is what we call as a staggered overdose. Any amount of paracetamol, irrespective of the dose, taken over and beyond a period of 1 hour is classified as staggered overdose. And the third type of poisoning is what we call as supratherapeutic excess. And most commonly people in the UK take it because they have dental pain. Instead of taking the maximum dose of 4 grams per day, they take 5 grams, 6 grams, supratherapeutic excess. And the management of each one of them is completely different. And people fail to understand this, and they treat all of them exactly the same. So single acute ingestion is ingestion over a period of 1 hour. Staggered overdose is over a period of 1 hour, and anything little bit extra above and beyond what a 70 kg adult can take, 5-6 grams, is called supratherapeutic excess. Paracetamol commonly affects the liver and the kidneys. And liver damage doesn't occur until, or doesn't start to happen until up to about 8 hours into the ingestion. And if you take paracetamol today, in 16 hours time, the liver should break it down and the levels should become 0. So in people who have taken paracetamol as a staggered overdose, or somebody who has taken paracetamol beyond 16 hours, this nomogram doesn't work. And relying on paracetamol levels to treat patients with staggered overdose is the commonest cause of mistreating a patient with paracetamol overdose. Misinterpretation of paracetamol levels is the first pitfall. So in a patient who has taken staggered overdose, you cannot rely on the levels, because if you look at the nomogram, you can see that at 16 hours it's almost 0, or at 24 hours. If you have a patient who has taken a staggered overdose of paracetamol, having a high level of paracetamol doesn't tell you whether you need to treat them or not. All it tells you is that they have taken significant amounts of paracetamol. If somebody hasn't taken significant amount of paracetamol, you won't find paracetamol level in their blood, because paracetamol disintegrates after 16, 18, 20 hours. So relying on levels in somebody who has taken a staggered overdose is completely unhelpful. If you have a patient and you suspect that you don't know the dose, toxicology patients don't tell you the truth, they don't tell you the amount, they don't tell you the time, and they don't tell you what they have taken. So you have to treat them on the basis of 3 things. Number 1, which Dr. Sharat will talk about later, is the concept of toxidose. And number 2 is the story. And number 3 is the tale. You have to put all the pieces together. So in somebody who comes in with a staggered overdose, assume that it is a significant poisoning. And unless you can prove that after 4 hours of the last dose of ingestion, they don't have GI symptoms, They don't have acute liver failure, they're not jaundice, they don't have abdominal pain, they're not vomiting, their ALT is normal, INR is normal, and paracetamol level is normal. Then you can safely say they haven't taken a significant overdose and you discharge them. So that's the first pitfall. Second pitfall is misrecognition of staggered overdose, which I've already alluded to. So the guidance is in all patients with suspected staggered ingestion of paracetamol, the guidance is you start N-acetylcysteine as soon as possible. We do not wait for the blood test. We only do bloods 4 hours after the last ingestion, and if they don't have symptoms, INR, ALT, paracetamol levels are normal, then you can stop the ingestion and you can discharge them. Failure to properly interpret liver function tests. Most people forget to look at liver function tests, and all they do is somebody come in with a single ingestion, you wait for 4 hours, you draw the bloods at 4 hours, and they find that their paracetamol level is normal. They ignore the other liver function tests. And the most important test is ALT. ALT rises much earlier than paracetamol level. INR rises much earlier than paracetamol level. If you fail to look at ALT levels and only look at paracetamol level, because on the nomogram, a paracetamol level at 4 hours of 100 or more is significant. But if the patient has got a level of 20, which is not significant, but with a raised ALT, and you fail to recognize, pick up, identify the rise in ALT, already liver damage has started and you've missed the boat. And in 8, 10, 12 hours, it will turn into irreversible liver damage. And then you're heading for a liver transplant for this patient. So 3 things: delaying treatment in staggered overdoses, relying on paracetamol levels to treat the patients, misinterpretation of paracetamol. And the 4th common thing, and the most common reason why people don't treat or don't receive treatment for paracetamol overdose is not this: delayed administration of NAP. Delayed administration of NAP. In our emergency department, over a period of 24 hours, we see 600 adults and 200 children. The wait time for an ambulance to come into the hospital is somewhere between 4 to 6 hours. The wait time for a patient to be seen after triage is somewhere between 12 to 14 hours. So although the patients are triaged within a few hours, they have their blood tests taken. Because the departments are busy, the nurses are busy, the blood results are not cascaded. I have come onto a shift and noticed people who had paracetamol levels requiring treatment, and the treatment wasn't started for more than 4, 6, 8, 10, 12 hours. And when you go to review these patients, and when you want to start them, they're already developing signs and symptoms of liver failure. So delayed treatment with NAP. And always remember, at least in the European countries, patients who present with poisoning usually, not always, usually have an underlying mental health disorder. So we need to address 2 things. We need to treat the physical symptoms as well as the mental health symptoms. You may be discharging them from a physical point of view, but they still need mental health. And there are lots of patients who will refuse to have treatment and they lack capacity. So you need to address that issue as well. So 4 things why we think we can treat paracetamol very well, but the common mistakes, even the best of toxicologists, they fail to identify correctly, interpret correctly, treat correctly patients with paracetamol poisoning. Number 1 is misinterpretation of the liver function test. Number 2, missing treating patients or delaying treating patients with staggered overdose. Number 3, relying on the paracetamol levels to treat staggered overdoses. And number 4, delayed administration of N-acetylcysteine. Of course, if somebody is allergic to N-acetylcysteine, it is not an allergic reaction, it's only an anaphylactoid reaction. You can give oral methionine. I'm not sure whether it's available here. It's not available even in the UK. US people do give some oral methionine. But otherwise, NAC is safe. Of course, you even treat patients with paraquat poisoning sometimes with NAC. And nowadays, in US, you could even buy NAC because it is an antioxidizing property for good health. So treatment protocols, you're clear about acute poisoning, staggered overdose, supratherapeutic access. Later on, Dr. Vishwa is going to talk about toxic alcohols, another topic which is very close to my heart, and fomepizole is used for the treatment of toxic alcohol poisoning. But you can use fomepizole even to treat patients with paracetamol poisonings, particularly in patients who have ingested large quantities of drugs. And we use what is called as the aminotransferase index for this. Aminotransferase index is nothing but the multiplication product of the liver enzymes, ALT, AST, times the paracetamol level. And if the answer to that is more than 10,000, then fomepizole is likely to be effective. In the olden days, we used to use what is called as the 21-hour regimen for NAC. So you give 3 bags, the first bag over 1 hour, second bag over 4 hours, third bag over 16 hours. And patients had to remain in the department for 21 hours. And as I said, most of these patients are mental health problems and they don't like to stay in hospitals. So they don't comply with the treatment. Halfway through the treatment, they drop and they leave. So to mitigate this issue, to reduce the number of anaphylactoid reactions, to increase compliance, for better treatment, shorter duration of treatment, we have introduced in the last 3-4 years what is called as the SNAP protocol. SNAP is Scottish N-acetylcysteine Accelerated Protocol for Treatment. Some people also call it as Scottish Antiemetic Protocol for Treatment. You use the same dose which you use in the 21-hour regimen, but you give it over a period of 12 hours. So the dose of drug that is being delivered to treat is the same, but you use 2 bags. First bag over 2 hours, second bag over 10 hours. And that's a 12-hour protocol. So 21 versus 12, they are the treatment protocol. We've talked about fomepizole. And there are some novel biomarkers. So traditional versus SNAP, we've talked about it. Fomepizole, we've talked about it. And all these biomarkers are there. Essentially, these biomarkers are looking for early signs of cellular injury at the cellular and mitochondrial level for liver. And if they are raised, then they show that the patient might have significant liver injury from paracetamol poisoning. So in conclusion, we've talked about the types of paracetamol poisons or the types of doses: acute injection, staggered overdose, and supratherapeutic excess. We've talked about the 4 pitfalls: delayed administration of NAC, failure to identify correctly the liver enzymes, failure to treat patients with staggered overdoses, and relying on paracetamol doses or levels for the treatment, and the management, which is the traditional versus the accelerated program. Every drug is a poison, and it's only the dose that makes the difference. Paracetamol is the most common poisoning in the UK, most common cause for acute liver failure, most common cause for drug-induced indication for liver transplantation, and the most common drug which is badly managed by physicians around the world. So dear friends, my only request about this to you is to be humble about the disease and the management of paracetamol overdose. Thank you very much.
Thank you, sir, for your insight. And I'd like to invite any questions from the audience.
How do you divide the dose in the SNAP protocol? Like you are telling you are giving for 2 bags. In the previous protocol, we are giving for 3 bags. Like say that the patient requires around 9 grams of NSL-16. So we are dividing it as 150 ml per kg body weight, followed by 50 ml per kg body weight, then 100 ml per kg body weight. So in SNAP protocol, you are telling you are giving only 2 doses. So how we are going to do it?
150, 50 and 100 is how much? 300. So in the SNAP protocol, you divide the 300 into 2 bags.
So, so initial first bag we need to give larger doses or how?
100 and 200, right?
Oh.
Yeah. So the same 300, which is 150, 50 and 100 over 3 bags, 1 hour, 4 hours, 16 hours, is given in 2 bags, 2 hours and 10 hours, 100 and 200. So the dose of N-acetylcysteine which the patient receives is the same. The duration is reduced. The number of bags are reduced. And as a result, what happens is patient compliance increases, lesser length of stay in the hospital, better treatment, and also lesser risk of anaphylactoid reaction. Because the first bag is what is the reason for somebody getting an anaphylactoid reaction. And in the older protocol, you were giving 150, and here you give 100. It's not an anaphylactic reaction, please bear it in mind. So you give chlorpheniramine, you give prednisolone, you give fluids only to make yourself happy. It doesn't do anything to the patient, other than giving the symptomatic relief. All you need to do is stop the bag, like in a febrile hemolytic reaction, stop the bag and restart at a slower rate. So in the older protocol, if somebody developed an anaphylactoid reaction, if you were giving the first bag over 1 hour, then you double the time, you give it over 2 hours. And the second bag over 4 hours, you double it and give it over 8 hours. So that the risk of anaphylactoid reaction continuing is minimized.
Thank you, sir. Thank you for your elaborate presentation.
Thank you very much.
So I have not question, sir. So in India, so it is not paracetamol that is commonly used for the pains. So like this one, tramadol and aceclofenac. So this has been never studied, I believe. Of course, paracetamol they will take it, but this can be what is called extrapolated to this, or we need to have some more studies. Please, if in one word you can enlighten us. This is a great question to all the younger minds.
Absolutely, yeah, this is a fantastic question. Now, in India, obviously, I always used to say paracetamol poison, and every time I spoke to my friends here, they said, in India, if you prescribe paracetamol, they actually question whether you're a doctor. Because they want some stronger analgesics, non-steroidals, COX inhibitors, gabapentin. Now, my father went to a neurologist and he prescribed him gabapentin. He's got no neuropathic pain. And in the UK, gabapentin is very, very carefully prescribed. And for those of you who do not know, gabapentin and gabapentinoids increase the suicidal risk tendency for patients. So they're not prescribed for a long duration. So paracetamol is not studied because people don't prescribe it here a lot. Now in the UK and European countries, we don't have the luxury of a lot of painkiller medications in our emergency department. The other day, one of the doctors migrated from here and he said, have you got IM diclofenac? We don't have IM diclofenac. We have PR diclofenac, which we give only for renal colic patients. We have paracetamol, we have ibuprofen, we have codeine and tramadol, otherwise IV preparations like morphine and fentanyl. Beyond that, sorry, we don't have any other medication available. So the armamentarium is less. The government regulation is you can only buy 2 packets of paracetamol from a supermarket. But unfortunately, the government also, although they know, they don't realize that a patient can hop from one supermarket to the second, to the third, to the fourth. And these people go to 5 supermarkets and they stock up paracetamol, so they've got 100 tablets. And every time they want to break up with their boyfriend, girlfriend, or they want to trouble their mother or father, they take 50-60 paracetamol like Smarties. It is a very, very, very common poison. We treat at least 2 patients every other day with NAC. And at least 5 to 10 patients a year end up with liver failure. And 1 patient a month, we do this problem of misdiagnosing and not treating properly. Despite lots of education, despite having very rigid protocols, people fail, misinterpret, misrecognize. Because it's a poison which can easily be treated, but at the same time it's very, very harmful drug. It's a very simple drug, very cheap medication, 16 paisa or 16p for 1 packet of 8 tablets. It can cost lives. I'm not sure here what analgesics people take overdose on. Are there any analgesics people overdose? Tramadol, opiates. Well, opiates is obviously, it's a big issue there. You have people, and there are a panel discussion coming up about opiates and why people don't respond to opiate, etc. I think there was a question here. We'll take up the last question in the interest of time.
Sir, any comment about the pediatric overdosage of paracetamol?
Same thing, sir. It's weight based on. Even pediatric, most of the pediatric poisoning is accidental.
Accident.
Most of them are accidental. Usually, unless you want to kill the child, but nobody gives paracetamol to kill child. Non-accidental injury is very common in the UK, but nobody kills them by giving paracetamol for some reason. It could be easily done, but they don't. But they don't same. The treatment remains the same. The protocols are for patients less than 40 kg and more than 40 kg. Daniel Welch was 35. So for all practical purposes, although she was 19, in terms of treatment for NAC, if people identified the paracetamol overdose at the right time, she would have received pediatric dosage of NAC. Thank you very much.
Thank you, sir. And I'd like to request sir to please come onto the dais to receive a memento. And I'd like to request Dr. Anuradha ma'am to present memento to sir.